Hello, my name is Shannon. I'm a vascular sonography student at Jackson College, and today we're going to be going over a case study that was performed back in November of 2018. This is a case of chronic bilateral common carotid dissection. The patient is a 55-year-old female who already had a known thoracoabdominal dissection that was diagnosed back in 2012. A unilateral common carotid dissection is a very rare occurrence. It's only about 1.7 patients in every 100,000, so the incidence of a bilateral common carotid dissection is even more rare. So in this case, a chest CT was performed November of 2018 that does show the aortic dissection. Also, it did show the common carotid dissection on both sides, but failed to show any extension of disease beyond the common carotid arteries. When we did our duplex exam, first on the right side, we have some beautiful pictures that clearly show the dissection, the true lumen and the false lumen. This would be the prox CCA, the mid CCA, distal CCA, ICA bulb, and then the proximal portion of the ICA. And what you can see here in B-mode imaging is that dissection, and that it stops at the bulb portion. When we come over here, this is a color image of the same area, and this is in the mid CCA region where we can see the antegrade flow going towards the head and the retrograde flow in the false lumen. When we got over to the left side, we had very similar pictures in the CCA portion, but once we got into the proximal ICA, things were a little bit different. So what we noticed is that the dissection actually appeared that it extended into the ICA. Now we couldn't see on the screen the actual echogenicity of the false lumen, but when we put color in, we were able to show that that dissection truly was there. When you come over here, I have a picture of the distal internal carotid artery, and as you can see, the dissection is still present. We put power Doppler inside and took a reading, and you can clearly see the retrograde flow that is going through that portion of the lumen. And it's almost at a stenotic level. What our stenotic range starts at 150, and it was 145 peak systolic velocity. So sort of right on the edge. This is a very clear, indication of extension of disease that the duplex ultrasound was able to diagnose that the chest CT was unable to do. So this is a great example of why duplex ultrasound imaging in the care and management of disease is definitely a win for the entire medical community. Thank you so much.